Okay, so we'll begin. I think we can begin now. Good morning, good afternoon, good evening from wherever you are. Thank you everyone once again for joining. It's really heartwarming to see a very good number of participants and those who are interested in this topic. So we are back with another EMA webinar series. So recently the Ethiopian Dermatovenereology Society created a partnership with EMA to give continuous medical education lectures and discussions every 2 months. So this is our first webinar session, and this webinar series will continue being given every 2 months, where our expert guest speakers will discuss on various dermatologic and venereal diseases. So our topic for today, as you have seen it on the poster running through social media, is the role of dermatopathology in the diagnosis of Mycosis Fungoides. We have a very prominent guest speaker with us today, Dr. Fuad Temam, and I will begin by introducing him with his academic and professional achievements. So Dr. Fuad earned his medical degree in 1993 from University of Leipzig, Germany. The same year, he received his diploma in tropical medicine and community health from University of Heidelberg, Germany. He earned his specialty certificate in Dermatovenereology in 2000 from the same university where he finished his medical school, and his fellowship in Dermato-pathology in 2006 from the Ackerman Academy of Dermato-pathology, USA. He has an honorary assistant. He was an honorary assistant professor at Addis Ababa University from January 2004 to September 2008. He was also a director of training division at Alert Hospital from March 2007 to September 2008. He was an assistant professor in the year 2008 and 2009 in the same university, Addis Ababa University. So he was a president of Ethiopian Medical Association from June 2009 to February 2011. He earned his international board certification in dermatopathology in December of 2015, Frankfurt, Germany, by International Society of Dermatopathology. Currently, he is a consultant dermatopathologist in Cadisco General Hospital, and also an assistant professor at St. Paul Hospital Millennium Medical College since September 2019 to date. So without further ado, I will leave the stage to Dr. Fuad Temam. And before that, I want to say that the first section will be a presentation with Dr. Fuad, and then we'll continue with the question and answer session, followed by post-webinar tests, which you should answer more than 50% of correct answers, so that you will receive your certificate of the CME certificate. Thank you. Over to you, Dr. Fuad.
Thank you very much, Dr. Ipsa. I'm glad that there are quite a number of interested colleagues who wants to share and hear the role of dermatopathology in diagnosing of Mycosis Fungoides. It's not really unique to the Mycosis Fungoides. I just want really to bring up the issue of the importance of correlating of the clinical or the gross pathology with the histopathology. Since I need to take one example, that's why I chose Mycosis Fungoides as a example. So I will go to the objectives first, and the objectives, as you can see, is by the end of this session. The participants will be able to describe the clinical pathology correlation of the Mycosis Fungoides, and the enabling objectives for this session are describing the epidemiology of the Mycosis Fungoides and listing frequent extracutaneous involvement of Mycosis Fungoides, and describing the clinical features of the condition and listing the histopathologic features of Mycosis fungoides. And most importantly, at the end is establishing the clinical pathologic correlation of Mycosis fungoides. So this is my outline of presentation. I will go through the introduction, the clinical features, the extracutaneous involvement of Mycosis fungoides, the histopathology with its variants, the association of MF with other diseases, the clinical and histopathologic variants, and more so the histopathologic differential diagnosis and the immunophenotype. As an introduction, as you all know, the Mycosis fungoides was first described by Heidelberg, was back in 1806. And we know that Mycosis fungoides is the most common form of cutaneous lymphoma. Almost half of all lymphomas arising in the skin are attributed to Mycosis fungoides. Vast majority of patients with Mycosis fungoides, more than 90% of them, they do present with early Mycosis fungoides, neither progress to tumor stage, no manifest extracutaneous. So this is, I think, a very important point whenever we encounter patients and when we disclose the diagnosis of Mycosis fungoides, and if we carry them at a very early stage, that of the patch stage, in terms of prognosis, it's very important to mention this research finding. Over 90% of those patients, they will remain with their patch stage of lesions for the rest of their lives, and they die mainly of any other natural causes. So the etiology of this condition is not known, but the incidence of Mycosis fungoides worldwide is about 6 to 7 per million. But there is a higher incidence and early onset of disease encountered in dark-skinned individuals. So the clinical manifestation of Mycosis fungoides can be divided in 3 stages morphologically: the patch, the early stage, and the plaques, and the tumors. So these 3 stages of Mycosis fungoides, they do reflect the activity of the condition, and they also correlate well with the prognosis of the condition. Clinically, the patches are described by variably large erythematous in fair-skinned individuals, but hypopigmented patches with finely scaling and wrinkled surface in dark-skinned individuals. So these are the clinical findings of the early patch stage of Mycosis fungoides. And these lesions can be either localized or sometimes they may be generalized. Those patches with time, they can progress to plaques. Like any condition, these lesions have lives, so they do evolve from the patches to plaques. So when they reach the stage of plaques, all what we see is clinically those patches are infiltrated and they do display variably scaling, erythematous brownish lesions. But patches can also be seen at the same time with plaques in the same patient. So those plaques further may develop or evolve into tumor stage, but those tumors may also be observed alone or within the patches and plaques of skin lesions. And again, those tumors can be isolated or they can be generalized. As an important point to mention is in tumor stage of Mycosis fungoides, most of the lesions do show ulceration of the surface. Apart from the skin, the Mycosis fungoides most commonly affects the lymph nodes, the lungs, spleen, the liver. These are the most frequent sites of extracutaneous manifestation of Mycosis fungoides. So this slide shows a well-defined silver hue of plaques. This is very common in dark-skinned individuals. Unlike in fair-skinned individuals, the erythemas are not visible. There is an absence of erythema, but the plaques are a well-defined, slightly raised skin lesions that are skin-colored, but because of the presence of the silvery scaly, you have sort of silvery hue. Here we're looking at the extracutaneous involvement sites that are affected most frequently in cases of Mycosis fungoides: the lymph nodes, the lung, the spleen, the liver. But nevertheless, specific lesions of Mycosis fungoides can arise in all organs of the body, but the bone marrow is usually spared from this condition. As a general rule, enlarged lymph nodes, lymphadenopathy associated with Mycosis fungoides lesions do represent a bad prognosis. This clinical finding is showing a hyperpigmented plaque, which is well-defined, a flat, if you like, really the elevation of this plaque lesion. If you look at on the right side, it's very, very subtle, slightly elevated from the normal skin, and it's hyperpigmented. Notice as a clinical feature, those wrinkled surfaces, like cigarette paper-like appearance. It's a helpful clue in clinical diagnosis. Again, this patient has also infiltrated papular erythematous lesions, and also an enlarged lymph node in the inguinal region, which is indicating of a bad prognosis of this condition. So this patient has a flat plaques that have evolved from the patch lesions with silvery hue appearance because of the presence of the scales and the wrinkled surface and associated erythematous papular lesions due to infiltrates of those neoplastic lymphocytes. To mention a few general points about the histopathology of the Mycosis fungoides, as a general rule, the proliferation of those neoplastic lymphocytes are small to medium size, and they are pleomorphic, meaning atypical. They have a cerulariform lymphocytes. And the other point is the intraepidermal collection of lymphocytes. Actually, this collection of lymphocytes within the epidermis was first identified by Derrier. And in fact, Potre acknowledged also, he was puzzled actually, this collection of lymphocytes have been named after him. They are seen only in few patches of Mycosis fungoides. When we see them, they are very important histological findings, but we do not expect them to be there in each and every cases of Mycosis fungoides. So the definitive diagnosis of Mycosis fungoides, like any other skin conditions, require careful correlation with the clinical findings. At times, multiple biopsies are needed to be taken from different lesions. And if necessary, the biopsy needs to be repeated at least 2 weeks after cessation of the local treatment that has a potential to alternate or to has an impact on the histological finding. Here we look at the useful diagnostic clues histopathologically in cases of Mycosis fungoides. As it had been mentioned earlier, the presence of epidermotropic lymphocytes with slightly larger nuclei than those within the dermis. Remember, in many of the inflammatory skin conditions where we expect to see inflammatory cells, in that case, lymphocytes, their presence within the epidermis, what we call exocytosis of lymphocytes. These are normal appearing lymphocytes. Whereas in cases of epidermal tropism, these are neoplastic lymphocytes. Histopathologically, they are characterized by having a larger nuclei as compared to those of lymphocytes within the dermis. And the presence of pleomorphic lymphocytes along the basal layer of the epidermis, they are lining up at the dermo-epidermal junction, is again an important clue in diagnosing mycosis fungoides histopathologically. And the presence of many intraepidermal lymphocytes in collections. In inflammatory conditions, you expect to see a significant spongiosis whenever a lymphocytes migrating from the capillaries within the papillary dermis upwards towards the epidermis. They do induce intercellular edema, and that's makes the spongiosis significant. Whereas in mycosis fungoides, the presence of many intraepidermal lymphocytes, they are associated with areas of very scant spongiosis, disproportionately little spongiosis, and sometimes spongiosis may not be even discernible. Another important point to mention is in about 5% of cases, in minority of cases of mycosis fungoides, the epidermotropism may be very minimal or missing altogether. And this is very true, especially for those patients who are presenting with a tumor stage of mycosis fungoides, where the findings are significant within the dermis, but the presence of pleomorphic lymphocytes within the epidermis is completely missing. So we will go step by step to the histopathology finding of the mycosis fungoides. On this slide, we discuss the histopathology of the early lesions of mycosis fungoides. So now, at early stage of mycosis fungoides, it is not easy to make the diagnosis on histopathologic findings alone. If you take, for example, the epidermis at the early stage of mycosis fungoides, it can be normal, it can be atrophic with diminished reticules, or it may be hyperplastic. And usually the presence of solitary lymphocytes can be seen, meaning the presence of pleomorphic lymphocytes as a solitary units, but collections of those pleomorphic lymphocytes, what you call the Darier's nests or Potrier's microabscesses, are rare. And you may see a patchy lichenoid or band-like infiltrates of lymphocytes within the fibrotic papillary dermis. When we say a fibrotic papillary dermis, usually in normal situation, we do expect to see a delicate bundles of collagen within the papillary dermis. But at the early stage of mycosis fungoides, those patchy lichenoid lymphocytes are situated within a thickened bundles of collagen, which can display a form of a chicken wire appearance. Presence of eosinophils is not a diagnostic feature, but they may be seen. But if they are absent, it doesn't really put any significant finding. Langerhans cells are increased in numbers, those within the epidermis and in the underlying dermis. How about the histopathologic finding? in the patch stage or in plaque stage. So at this stage of the condition, the epidermis is parakeratotic, meaning the nuclei of those keratinocytes are retained. And this can be seen either as a patch or sometimes it is confluent, meaning involving the whole of the conified layer with the retained nuclei of those keratinocytes. The spongiosis is very subtle, and those lymphocytes that are seen both within the epidermis, the epidermotropic lymphocytes, and those neoplastic lymphocytes that are distributed within the dermis are hyperconvoluted. There is a lichenoid infiltrate of, again, small and medium size of lymphocytes, and few histiocytes can also be identified within the neoplastic pleomorphic lymphocytes. Potrier's microabscess or Derrier's nest is a common finding in a patch/a plaque stage. Papillary dermal fibrosis, like that of in a case of early or patch stage of Mycosis fungoides, can also be seen in plaque stage. And the lining up of isolated lymphocytes at the epidermal junction are an important histological feature at this stage of the condition. Immunohistochemistry and T-cell gene rearrangement studies can help to show the clonality of those lymphocytes, because the presence of lymphocytes, they can also be seen in inflammatory conditions other than the neoplastic conditions, like in that of Mycosis fungoides or other forms of cutaneous lymphomas. So if we do the immunohistochemistry, or if we have the setup to conduct the T-cell gene rearrangement studies, we will be able to see the clonality of those neoplastic lymphocytes. Here we see the early patch stage of Mycosis fungoides. Actually, this patient was presented at St. Paul Hospital, Millennium Medical College. You can see this relatively well-defined hypopigmented patch. Sensation is intact. Leprosy is a differential diagnosis clinically. So this was an asymptomatic lesion which were there for a couple of years. And this patient is a female, age 23. So the histopathologic finding that correlates with this patch stage, as you can see, you have the epidermis, that is in this case hyperplastic, meaning acanthotic, but it could have been also atrophic or normal. In this case, we can see the acanthosis of the epidermis. You see the top where the conified layer are retaining some of the nuclei of the keratinocytes. And most importantly, you can see those neoplastic lymphocytes. So these are neoplastic lymphocytes because they are large in size and their shape is a bit of a cerebriform, solitary, but here they are in collections. If you like, it's a kind of a subtle form of Derrier's nest or Potrier's microabscesses within the epidermis. So the collection of those pleomorphic neoplastic lymphocytes, cerebriform lymphocytes in small collection, that's what is represented as a Derrier's nest or Potrier's microabscess. Same patient, the clinical picture is showing multiple. Here you have one, here you have another larger one, here at the back, almost confluent with the other large hypopigmented patch. I just want to mention that this form of Mycosis fungoides, the hypopigmented form of Mycosis fungoides, is very common in dark-skinned individuals. So this patient didn't have a loss of sensation on this hypopigmented patch, and she didn't have any peripheral nerve enlargement. And the skin pathology, the biopsy taken from the hypopigmented patch is showing the normal conified layer in a way showing the basket weave pattern and slightly hyperplastic epidermis, acanthotic epidermis. Notice the lining up of lymphocytes at the dermoepidermal junction. These are lymphocytes because they are monomorphic and hyperchromatic. Since they have a very scanty cytoplasm, they can be discernible by their monomorphic hyperchromatic nuclei round, and these are the smallest cells. And their presence also you can see in a small collection within the epidermis, the lining up at the dermoepidermal junction here, and their presence in a solitary units and in small collections like this one here within the epidermis. So the histopathologic finding, as you can see here, can be very subtle. So at the higher magnification of the same slide is showing pleomorphic lymphocytes. Pleomorphic lymphocytes, you can see them. You can see here as a solitary units, large in size, hyperchromatic, and irregularly shaped. And look at those lymphocytes in small collections within the epidermis. Those ones are solitary neoplastic pleomorphic lymphocytes within the basal layer of the epidermis. Another small collection of lymphocytes within the basal layer of the epidermis. And again, small collection over here. So if you look at the collagen bundles within the papillary dermis, they kind of display a chicken wire appearance, showing that the bundles of collagen within the papillary dermis is thickened. That's what we meant by a fibrotic dermal collagen within the papillary dermis. Another important clue histopathologically in case of Mycosis fungoides. So this picture is showing hyperplastic epidermis, the acanthotic epidermis. If you see the codified layer up here, it goes down there. So it is relatively hyperplastic, acanthotic, with elongated arete ridges. The epidermal tropism of those neoplastic lymphocytes are seen at all levels of the epidermis, but here in a clear collection, another collection of neoplastic lymphocytes, a third one over here, characteristic of Darier's nest or Vautier microabscess. So next we move to the plaque stage. This patient is displaying a very large, well-defined plaque, which has a normal skin color. If you compare, for example, the normal skin color of the brown color of this normal skin with the edge, with the border slightly elevated plaque lesion of this patient. But when you look further to the left, you can see the silvery high. It's very common in dark skin individuals because of the presence of the scales on the surface with the normal appearing skin as an island in between. So the histopathology of the plaque lesions, the histopathology of the plaque lesions are characterized by a confluent parakeratosis and acanthosis or hyperplastic epidermis. And you have a dense band-like infiltrate of lymphocytes within the upper dermis, and the eosinophils and plasma cells can occasionally be identified. So the intraepidermal lymphocytes, they are arranged in collections forming darriers or portraits microabscesses. This is very common in plaque stage, but it can be completely missed in a tumor stage, and it can be rarely seen in patch stage of mycosis fungoides. So the cytomorphology of those neoplastic lymphocytes are small to medium size, pleomorphic, meaning irregular in shape, some display cerebriform. So they do predominate in the plaque lesions. And those coarse collagen between the epidermis and the infiltrates of the neoplastic lymphocytes are also a common finding in the plaque stage of mycosis fungoides. So as you can see on this slide, you have a confluent parakeratotic area with acanthotic and hyperplastic epidermis. And notice the band-like lymphocytic infiltrate, which starts from the right towards the left. It cuts the swath through the superficial dermis. These lymphocytes, they are characterized by their appearance as a dark bluish in color and monomorphic in their nucleus coloration. So at the higher magnification, this is the cytomorphology, predominated by small to mid-sized pleomorphic lymphocytes, irregular in shape. Some display a cerebriform pattern. This slide is showing a manifestation of mycosis fungoides at its different stage. Let's start with the patches. If you look at this area, this is a patch because it's a flat lesion and it's hypopigmented compared with this normal appearing skin. But notice the wrinkling, the surface wrinkling is very important. A hypopigmented patch with a surface wrinkling. And here adjacent, we can see the plaque. As you can see, this lesion is large and has a well-defined border, slightly elevated from the skin surface. But you have also multiple tumoral lesions. Notice the ulceration of the surface of those tumors, which is a very common finding clinically in tumor stage of mycosis fungoides. Again, here also infiltrated papules, erythematous infiltrated papules can be seen. So you have basically the early stage of mycosis fungoides in form of patch in these patients, and also the plaque and the tumor stage. So this is not uncommon to see in patients with mycosis fungoides presenting in a very advanced or late stage. So a few points about the histopathology of tumors of mycosis fungoides. The histopathology finding of those patients presenting in a tumor stage or where a biopsy has been taken from the tumor's lesion, we do see a dense nodular or diffuse infiltrate present within the entire dermis. And at times, those infiltrates can extend into the underlying subcutaneous fat. So the second point is what I had mentioned earlier, the epidermotropism, what we expect to see at the early stage of mycosis fungoides in a patch or in plaque stage may be completely lost in a tumor stage. So some flat tumors, they do show dense infiltrates of pleomorphic neoplastic lymphocytic infiltrate that are confined to the superficial and mid parts of the dermis. And sometimes flat tumors may also present with a predominantly interstitial infiltrates. So this can be a difficult situation, because if you have a predominantly interstitial infiltrates of lymphocytes, histopathologically, the differential diagnosis would be the interstitial form of granuloma annulare or the interstitial form of morphea. So the clinical pathology correlation would be extremely important to establish the final diagnosis. And at last, the tumors of Mycosis fungoides are morphologically indistinguishable histopathologically from other types of cutaneous natural killer T-cell lymphoma. So this slide is showing the histopathologic finding of the Mycosis fungoides. As you can see, the epidermis is very thin, in fact, atrophic. You can see probably 2 or 3 cells thick, and it's effaced. You don't see the rated ridges. They are diminished because of the dense inflammatory cell infiltrates, the dense neoplastic pleomorphic lymphocytic infiltrates within the entire dermis, from the surface down to the border between the reticular dermis and the subcutaneous fat. Another important point here is when you compare the infiltrates of those lymphocytes between the top and the bottom. At the bottom, you see them in a very dense and diffuse fashion. So we describe them as a bottom heavy. This is very important because in many of the inflammatory skin conditions, wherever you have a lymphocytic infiltrate, dense and diffuse lymphocytic infiltrates, that is top heavy. It's for practical purpose inflammatory condition. So whenever you have a bottom heavy, dense lymphocytic infiltrate, you always need to suspect of a lymphoma. Here we have the histopathologic picture of a flat tumor. Notice those neoplastic pleomorphic lymphocytes, they do involve only the superficial and the mid-dermis. They are confined to the superficial and the mid-dermis only. So we move on to conditions that are associated with Mycosis fungoides. So this is very important to mention that other form of cutaneous lymphoma, like that of the lymphomatoid papulosis and the anaplastic large cell lymphoma, the cutaneous anaplastic large cell lymphoma, Hodgkin lymphoma, and non-Hodgkin lymphomas of both T or B cell lineage. These conditions are all can be associated with Mycosis fungoides. And rarely, Mycosis fungoides may be present with completely unrelated lymphoma at the same skin site. In that case, the terminology composite lymphoma is being used. Finally, it's very important to mention that patients with tumor stage of Mycosis fungoides, since they will have large cell transformation, meaning with expression of CD30. So these patients, they can pose a diagnostic challenge because distinguishing these subsets from lesions of the lymphomatoid papulosis and the cutaneous anaplastic large cell lymphoma is very difficult, if not impossible. So we will look at the different forms of clinical and histopathologic variants of Mycosis fungoides. So you can have a pilotropic or folliculotropic, or in some literatures they are mentioned as a follicular Mycosis fungoides. And Mycosis fungoides can also present as a localized pagetoid reticulosis, also called Waringer collop. And you can have a granulomatous form of Mycosis fungoides, the rare variant being granulomatous slack skin. And patients may present with interstitial Mycosis fungoides. Actually, this form of Mycosis fungoides doesn't have any clinical characteristics, but this is a histopathologic diagnosis. And another form of Mycosis fungoides is a poikilodermatous or a Poikiloderma vascular atrophicans. And the hypopigmented form, we have already seen, taken the example from the patients, what we saw at the beginning, 23 years old girl, female patients from St. Paul Hospital and Millennium Medical College. And the purpuric Mycosis fungoides and the popular Mycosis fungoides are the clinical and the histopathological variants of Mycosis fungoides. So to mention a few findings about the individual variants of Mycosis fungoides in case of the pilotropic or folliculotropic or follicular Mycosis fungoides, we have clinically papules and plaques. These are confined to the infundibulae, and they show a protrusion of keratotic spines, and clinically they do resemble lichen spinulosus. Sometimes they may be associated with a small area of hair loss. And itching is severe in this form of Mycosis fungoides, and it represents a major problem. The overlying epidermis is usually spared, meaning you don't expect to see epidermotropism of the pleomorphic neoplastic cells in this form. Hair follicles are infiltrated by neoplastic lymphocytes, and at times you may be able to see the large deposition of mucin that disrupt the follicle. I just want to mention the point that in a condition when we see follicular Mycosis fungoides, the presence of mucin is not mandatory. In some of the patients, you may be able to see those neoplastic lymphocytes are infiltrating the hair follicles in association with deposition of mucin, but in some patients, the presence of mucin may be completely absent or lost. Whenever we have patients presenting with pilotropic form of Mycosis fungoides and associated mucin deposition, eosinophils are commonly identified. So here we have a histopathologic slide of a follicular Mycosis fungoides. As you can see, there is a dense infiltration of those neoplastic lymphocytes of the hair follicle. And these empty spaces, as you can see, this is displaying a presence of a deposition of mucin. Another example of a follicular Mycosis fungoides. Here you can see the epithelium of the follicle. It is infiltrated by those pleomorphic neoplastic lymphocytes. But in this case, it's a good example to show you that this form of follicular Mycosis fungoides is not associated with deposition of mucin in this case. Also on the right side, if you see, there is a dense lymphocytic infiltrates that are pleomorphic and neoplastic in the absence of mucin deposition. Here on the left side, notice how the bundles of collagen is thickened. The fibrosis or the thickened dermal change is in association with Mycosis fungoides. It's common. It just gives a clue that the condition has been a long-standing one. So in many of the skin conditions where the condition have been for a long while. You see the thickening of the bundles of collagen displaying a fibroplasia. The other form of Mycosis fungoides is the localized reticulated. The localized phagocytoid reticulosis. Clinically, this form of Mycosis fungoides is characterized by a scaly patch or a plaque. Usually, it is seen on extremities as a solitary lesion, and it is located to one acral site. Clinically, it can simulate a benign lesion like that of either a wart or an eczema. And those patients are commonly referred or biopsied because the long-term treatment for wart or eczema didn't work. So clinically, they are characterized by a markedly thickened epidermis with striking presence of neoplastic pleomorphic lymphocytes within the epidermis. And those neoplastic lymphocytes usually have a T cytotoxic phenotype, CD4 positive or negativity for both CD4 and CD8. And those lymphocytes, they may show tropism for adnexal structure. And sometimes it may be difficult to distinguish it histopathologically from the lymphomatoid papulosis type D, because in lymphomatoid papulosis type D, you have the phagocytoid spread of those neoplastic pleomorphic lymphocytes within the epidermis and mimicking the lymphomatoid papulosis type D. And also a band-like neoplastic lymphocytic infiltrate can be seen within the superficial dermis, again mimicking the lymphomatoid papulosis type D. But in general, the prognosis of these patients with solitary lesions of Warringer-Kollop is excellent. So here we have the clinical picture of the localized phagocytoid reticulosis, which is really mimicking kind of wart with a well-defined erythematous plaque, an irregular shape, and variably scaling surface. Another example, if you look at those two popular hyperkeratotic lesions, really, I mean, anybody can think of a plantar wart. This can be mistaken for a plantar wart. And a lesion, a close-up view can show a well-defined whitish hyperkeratotic papule. So the histopathology of the Warringer-Kollop here, as you can see, that's what I have mentioned. It can be easily mistaken histopathologically for lymphomatoid papulosis type D, because here you have a phagocytoid spread of those neoplastic lymphocytes at all levels of the epidermis, just similar to that of the phagocytoid melanoma, or that histopathologically seen as a phagocytoid spices nevus. And on the left side, you can see a band-like lymphocytic infiltrate within the superficial dermis. So the epidermal tropism of those neoplastic lymphocytes is very significant in localized phagocytoid reticulosis of Warringer-Kollop form. The granulomatous Mycosis fungoides, it is an unusual histologic variant of the disease, which is described first by Ackerman and Flaxman in 1970. They actually reported a patient with a tumor stage of Mycosis fungoides in association with the histiocytic giant cells within the dermal infiltrates of those neoplastic lymphocytes. So the granulomatous lesions may proceed, they may appear concomitantly, or they may follow the classic Mycosis fungoides. And again, like in tumor stage of Mycosis fungoides, also in granulomatous lesions, the epidermal tropism is often minimal or it's missing altogether. So this makes it difficult to distinguish from other cutaneous T-cell lymphoma with the granulomatous features. So granulomatous slack skin is a rare variant of the granulomatous form of Mycosis fungoides, and that will lead to the very important point that clinical pathology correlation become very crucial in establishing the final diagnosis. So the clinical picture of the granulomatous slack skin here can show the atrophy of the skin, which is characterized by a shiny, thin atrophic skin with a wrinkled surface in association with a bulky and pendulous skin folds on both sides, as you can see both on the right side and on the left side. So this is the histopathologic finding of the granulomatous Mycosis fungoides. Here you have infiltrates, dermal infiltrates of neoplastic lymphocytes within the dermis. You see them cerviform, neoplastic, irregular in shape. But within this neoplastic lymphocytic infiltrates, you have the histiocytic multinucleated giant cell with intracellular numerous neutrophils. So the interstitial form of Mycosis fungoides is a variant with no characteristic clinical presentation, as I mentioned earlier. So this form of Mycosis fungoides is a histopathologic diagnosis, and it's observed usually in flat tumors of Mycosis fungoides, and the histologic pattern may be misinterpreted as inflammatory conditions like that of interstitial granuloma annulare or interstitial form of morphea. And the presence of neoplastic lymphocytes within the epidermis and the band-like pattern may be completely lost. The dermal infiltrates of neoplastic lymphocytes, they are seen between the bundles of collagen. So most of them are T lymphocytes and freely floating collagen fibers that are surrounded by the neoplastic lymphocytes have been commonly observed. So the poikilodermatous variant of Mycosis fungoides is one of the most common clinical pathologic variants, and this is characterized clinically by atrophic erythematous brownish macule and patches with prominent telangiectasia, and the breast and buttocks are the predilection sites of this form, and the atrophic epidermis with epidermotropism, loss of rete ridges, and interface dermatitis and the band-like infiltrate of lymphocytes may mimic the lichenoid form of dermatitis, like that of the lichen planus, for example, with the interface dermatitis and pigment incontinence and presence of necrotic keratinocytes. So the dilated capillaries are present within the superficial dermis and the papillary dermis, which is thickened. And in some cases, the finding of the lichenoid band-like infiltrates with necrotic keratinocytes can pose a diagnostic challenge to distinguish it from the atrophic form of lichen planus. So the papular form of Mycosis fungoides, these are characterized clinically by papules. This is a predominant feature in some patients, but these papules may be small and they can be associated with patches. And the papules are not centered, is a very important clue. Those papules are not centered on the infundibulae. And the histology shows conventional features of Mycosis fungoides, but the infiltrates are restricted to one part of the biopsy specimen. The histological finding may be indistinguishable from the type B lymphomatoid papulosis. CD30 is usually negative, and there is no spontaneous regression like that of the lymphomatoid papulosis. You know that the lymphomatoid papulosis is a chronic recurrent condition, which is a self-limited one. Cells are CD30 positive, and the spontaneous regression is very common, whereas in the papular form of Mycosis fungoides, that is not the case. So the histopathologic differential diagnosis can be divided into two groups. The inflammatory important differential diagnosis for Mycosis fungoides is atopic dermatitis. As we all know, many of those patients, they have a prior history of treatment with topical steroids for atopic dermatitis. And also a chronic dermatitis is also another important differential diagnosis among the inflammatory conditions, and psoriasis because of the erythematous and scaly plaque. And pityriasis lichenoides also is very important differential diagnosis. Other neoplastic conditions or other cutaneous lymphomas that should be considered as differential diagnosis are the Sézary syndrome and the cytotoxic natural killer T-cell lymphoma. We are coming to the final slide of this session, talking about the immunophenotype. Mycosis fungoides is characterized by an infiltrate of alpha, beta, T helper memory lymphocytes, characterized by the beta F1 positivity and TCR gamma negative, and CD3 positive, CD4 positive, and CD4 positive, and CD8 negative. And the CD45 row is positive, and the TIA1 positive. But in a minority of cases, we may see a T cytotoxic phenotype, meaning where you have the CD4 negativity and the CD8 positivity with the TIA1 negativity. But nevertheless, this doesn't show any clinical or prognostic difference. So in these cases, again, the correlation with the clinical feature is a crucial to rule out other aggressive cytotoxic lymphomas. So in late stages of mycosis fungoides, the total pan T cell antigen, these are the CD2, that CD3, and the CD5, and or the CD4, CD8 expression may completely lost. I'm coming with the final slide, and these are my references, and I hope you have enjoyed the talk, and I would be happy to have your opinion, your feedback and questions. Thank you very much.
Thank you very much, Dr. Fuad. I'm sure this is a very well informative presentation. So we will continue with the next session, which will be the question and answer session. So Dr. Zaganesh, who is also a colleague in CME, will moderate the Q&A session. Over to you, Dr. Zaganesh.
Thank you, Dr. Ifsa, and thank you, Dr. Fuad Temam, for your excellent presentation. We have found 3 questions. The first one from Simon Isaac said, once plaque and patches tumors are seen, are there stages of remissions, or is it a continuous process until abating to a full-fledged T-cell lymphoma? And the second question is, how coming is this chance in Ethiopia? Or he's asking about the epidemiology in Ethiopia.
Thank you for the important 2 questions. If I missed the third one, you may remind me of again. Considering the patch, the plaque, and the tumor states of mycosis fungoides, these are really lives of lesions. In a majority of cases with mycosis fungoides, lesions start as patch lesions, meaning at the early stage, patients will have asymptomatic hypopigmented patches with intact sensation, unlike in the case of leprosy, with no peripheral nerve enlargement. So because of this, patients do not present early to seek medical advice. So it really doesn't do anything to them, because they have observed those lesions with no symptoms, and they can remain, as I mentioned earlier, in a majority of patients, in about 90% of those patients, they do remain with this stage of the condition as a patch stage. And that makes it also difficult to really get the epidemiology of this condition. especially in our setting where the health access is very, very limited. And as you can imagine, patients with hypopigmented patch with no symptom, no progression, so they won't care to seek medical advice. So those lesions, after a while, they can progress to plaque stage and then later to tumor stage. Only very few proportion of patients, between 5 to 10% of those patients will progress over many years to the tumor stage. So whenever you see a patient like I presented earlier in my talk, whenever you see a plaque lesions in a patient, it is very likely that you will find also a patch stage like I showed it earlier. And if you have patients with a tumor lesions of Mycosis Fungoides, you can see concomitantly the plaques and the patches. And in regard to the question about the epidemiology of Mycosis Fungoides in our country, I didn't come across any of a study that have been conducted. But if there is anyone in the audience can share the opinion, but as far as my knowledge is concerned, this hasn't been studied. And we don't know the exact epidemiology. And it's very important also to mention at this juncture that in general, in the pediatric age groups, Mycosis Fungoides is rare, but the real incidence may be higher than assumed because there is a reluctance of performing a skin biopsy in children. So those factors need to be into account when we think of the epidemiology of Mycosis Fungoides. Thank you. If I've missed one more question, please, you can remind me. I'm not sure if I answered all 3 questions.
Yes, you did, doctor. There's another 5 questions that came across. The first one, it says, how is the correlation of Mycosis Fungoides histopathologic variant with its prognosis and granulomatous Mycosis Fungoides versus folliculotrophic versus pagetoid pediculosis Mycosis Fungoides?
In regard to clinical pathology correlation, there is no question, as I emphasized in my talk. We really don't expect the histopathologist to give us the final diagnosis. Like in almost all skin conditions, with few exceptions. Like, for example, if I see Leishman-Donovan bodies within the cytoplasm of the macrophages, the diagnosis is cutaneous leishmaniasis. But in many instances, the histopathologists require a thorough clinical finding along with the history. So the clinical pathology correlation is really crucial to establish the diagnosis, and especially to make a specific diagnosis of the variants of Mycosis Fungoides, like, for example, as I mentioned earlier. That's why I put them in different slides to explain more in detail. Like, for example, if you take the folliculotropic or the pilotropic form of the follicular Mycosis Fungoides, clinically, the dermatologist will give these findings. In fact, some of the clinicians may be very good in describing those lesions. We see these popular lesions. They may also mention that they are not confined to the infundibulae, the ostia of the hair follicle, but they may also describe the partial loss of hair, and they may put even as a diagnosis lichen spinulosus. And really, this is an excellent description from the clinician. And if the histopathologist sees the infiltrates of those epithelia of the follicle, the epithelium of the follicle with neoplastic pleomorphic lymphocytes, then it's the best correlation. This is a Mycosis Fungoides. You have the infiltrates of neoplastic cerebriform lymphocytes, involving the epithelium of the hair follicle, sometimes in association with deposition of mucin, but sometimes in the absence of deposition of mucin, then this is an excellent phacopathologic correlation, and the histopathologist can, with surety, sign them out as this is a Mycosis fungoides, a pilotropic or a follicular form. In terms of prognosis, really, we don't have a specific finding to give the prognosis, except for few. For example, the prognosis of the localized pagetoid reticulosis or the Weringer Kolb type, they have an excellent prognosis. They are single lesions, and sometimes they can't even be excised surgically. They are gone. But in general, their prognosis is well studied. It's excellent. But otherwise, it's really individually different. As I mentioned earlier, 90% of patients with mycosis fungoides, they live with their early stage of mycosis fungoides for the rest of their lives, and they die of any natural cause. But sometimes they do progress after many years to plaque and tumor stage, and most of the time they do die either as a complication of secondary infection. Is a common way that they die.
Perfect. Thank you. Another question was, which type of histopathologic variant is common in our country from your experience? And another one is there a bullous type of mycosis fungoides, and if we can find the histopathologic picture of it.
It's very important questions. In my experience, the very common form of mycosis fungoides, what I witnessed is a patch stage. And those patch stages, those patients have been frequently treated as a case of either atopic dermatitis or any form of endogenous type of dermatitis, or as a form of chronic dermatitis. And in my experience, this is the patch stage of mycosis fungoides. And sometimes even the histopathologic findings are very subtle. I do see just the lining up of single lymphocytes at the dermoepidermal junction, otherwise very sparse, normal appearing lymphocytes, perivascular within the superficial dermis. And I do advise the clinicians to perform the repeat biopsy after 6 to 8 months. And there are cases that came up to a good correlation of the patch stage of mycosis fungoides. So in general, in my experience, the patch stage of mycosis fungoides are the commonest, but I had cases with plaque stage of mycosis fungoides, and also patients who have reached the tumor stage of mycosis fungoides. And I remember also 2 cases who have died at the end of their diseases. Both of them, they had a tumoral stage, and they died of sepsis. For the second question, again, it's a very important question. It's rare, but there is, yes, a bullous form of mycosis fungoides. In case of bullous form of mycosis fungoides, histologically, you do see the intraepithelial clinically form of a blister, but intraepithelial a fluid with very few plastic pleomorphic lymphocytes. I don't have the histopathologic picture for this one on this session, but probably it is possible to share it with the audience on another occasion.
All right, thank you. Another question is histopathology difference between flat tumor and patchy stage of mycosis fungoides. And to add on this, which lesions are good diagnostic outcome in case of mixed lesions like patches or plaque tumors in a single patient?
To the first question, the difference between patch and flat tumors. In case of patch stage of mycosis fungoides, you see, as I mentioned earlier, histopathologically, the presence of few pleomorphic neoplastic lymphocytes within the epidermis and the lining up of those neoplastic lymphocytes along the dermoepidermal junction, you don't see the confluent band-like neoplastic lymphocytic infiltrate within the superficial dermis. So that's the case in case of flat tumors. The epidermis is plastic, meaning acanthotic, but most of all, you have a dense band-like neoplastic pleomorphic lymphocytic infiltrate confined to the superficial and mid-dermis. So that is, I think, the distinguishing criteria between the patch and the flat tumors. Which one has a better prognosis? Again, you cannot determine the prognosis of a patient's condition based on the presence of either patch or plaque, because you don't know where these patients, when these patients do progress from patch to plaque and to tumoral stage. But obviously, in a clinical setting, when I communicate with a patient, most common ones that as I have described earlier with the patch stage, this is what I do emphasize. I think in our communication, it's very important really to tell them. I'm afraid some of us may use the term, once we have the diagnosis, you have a cancer. So you can imagine, considering the understanding level of our people in our country, it's really shocking, and they can really collapse. And unlike many of the neoplastic conditions, cancerous conditions, we need to emphasize to them that majority of patients with this diagnosis will remain for the rest of their lives with the same stage without progressing to tumor stage. I think this is a very important point. We should not deceive them. We should tell them that the findings show that about 90% of those patients will die of natural cause. So, but in terms of prognosis, yes, if I have a patient with patch stage, this is what I would communicate with the patient, and had a pretty much good prognosis, unlike that of patients with plaque or rather tumor stage.
Okay, thank you, Doctor. Yes, we answered it perfectly. We have another 3 questions that came along. Can you tell us your experience in the diagnosis of Mycosis fungoides in our setup where clinical information is not adequate? And another question from Bigafi is, how do you differentiate erythrodermic Mycosis fungoides from other erythroderma? And the last one is, most of the stock is focused on superficial parts of the adult patient. Is this Mycosis fungoides affect children, oral areas? And there's a comment in our country, it's already answered.
Okay, the first question is about the Mycosis fungoides, where there is no adequate clinical description is given.
Yeah.
As I mentioned earlier, it's very difficult. It's very difficult because I think I am repeatedly mentioning this point. It's not really unique to the Mycosis fungoides. As a general rule, the histopathology is a continuation of the gross pathology, what we see, and it should be correlated. So the problem will be both for the patient, for the histopathologist, and for the clinicians. So if patient is sent to have a biopsy done, or if we receive a skin biopsy specimen from a patient without adequate clinical information, chances to misdiagnose is very high. No doubt about it. So I do sometimes really try to communicate with the requesting physician. And as you can imagine, it's not easy, because unfortunately, we don't put our contact address when we request tests or skin biopsies. And not every one of us have a contact numbers of the colleagues. But in a difficult situation, I do describe what I see histopathologically, and I put my diagnosis histopathologically, what I think is going to be likely, or I put also in an appropriate clinical setting, this could represent. That's how I sign them out and ask the patient, ask the physician also to repeat a biopsy and to provide with more clinical information. If it is very more convincing, if I see, for example, a confluent parakeratosis and presence of pleomorphic neoplastic lymphocytes in a solitary unit or in small collections like in that of variousness or portrait microabscesses, and with a band-like lymphocytic infiltrate, based on the histopathological finding alone, the histopathology findings represents a plaque stage of Mycosis fungoides. I do sign out sometimes when I have evidence convincing enough to sign them out as a condition, but we have to always attempt to establish the clinical pathology correlation. The other question was whether, in terms of age, as I mentioned earlier, I personally don't think that in general, we know that it's rare, but looking at the demography of our people, most of our people are youth, children in terms of number, and we have to compare how many children versus youth, and then the reluctance of performing biopsy on children is there. So these factors needs to be taken into consideration. But in my practice, in my experience, I had also patients with Mycosis fungoides as early age as 9 years old. So I don't think that they are extremely rare. In general, they are rare, but again, the factors that I had mentioned earlier needs to be taken into account, and a proper epidemiologic study needs to be conducted to say a precise finding.
Okay, thank you,
Coming
Dr.
back to Rafi's question, sorry, how I distinguish erythrodermic form of Mycosis fungoides from erythroderma of other origins. Actually, one of the practical issues why we need to take a skin biopsy from a patient with erythroderma, clinically erythroderma of patients having any underlying conditions, it resembles the same. That's why we need to take a skin biopsy. So the skin biopsy will help us in looking at the histopathologic findings of the underlying conditions, whether being it as a result of psoriasis, for example, the histopathologic findings of psoriasis will be there. So it aids in identifying the underlying cause, being it due to drug. So the histopathologic finding of the drug reaction will be there. So that is the helpful criteria histopathologically to identify the underlying cause. In case of purpuric form of Mycosis fungoides, you have the finding of histopathologic MF with extravasated erythrocytes. In poikiloderma, you have rather ectatic or dilated capillaries. So be it psoriasis or Mycosis fungoides or atopic dermatitis or drug reaction, in case of erythroderma, the aid of histopathology is really to identify the underlying cause that may have led to erythroderma.
Okay, thank you, Doctor. Our last question is going to be, can we differentiate the large plaque parapsoriasis with Mycosis fungoides on histopathological, and any correlation between these two? I guess both of them have these scaly lesions and the like. So how can we differentiate the two?
So it's a very important, it's actually a very important question, and it's a point of concept. You see, when I did my fellowship very long time ago in 2006, Professor Ackerman used to say, and has also written in the books, saying that small plaque parapsoriasis and large plaque parapsoriasis are mycosis fungoides at early stage. Many of the pathologists didn't agree. Now, after many years, if you look at the book written by Lorenzo Cerroni, Professor Lorenzo Cerroni, who is the director of the Dermatopathology at the University of Graz in Austria, who was a long time ago also a trainee of Ackerman, Werner Ackerman. He is considered to be a father of skin lymphoma. So he wrote a book on skin lymphoma. So in his book, many years later, he mentions, now we understand a large plaque parapsoriasis is a form of mycosis fungoides, even though the small plaque parapsoriasis cannot be exclusively considered as a mycosis fungoides. So you see, this is a really a philosophical issue. And in my experience, I really don't think that I'm influenced by the saying of my Professor Ackerman, but in my experience, many of the cases that I see requested by clinicians as large plaque parapsoriasis, they are mycosis fungoides. And from my observation, I do think we have many mycosis fungoides cases than assumed. I think this probably can be a very important topic, really, to see the prevalence or the epidemiology of mycosis fungoides in our country.
Okay, Dr. Fuad, with this, we wind up our question and answer. You have perfectly answered our questions. Thank you very much for your excellent presentation.
I thank you, the organizers, the moderators, and also the audience for their attention, for raising important questions. And I really learned quite a big deal from the questions raised by the audience as well. Thank you very much for giving me this opportunity.
Thank you, Dr. Fuad. It was a very wonderful webinar. We liked it all. So by this, we will wind up our webinar. Thank you very much, Dr. Fuad. So we'll see this team, the Ethiopian Dermatovenereology team, after 2 months with another very interesting topic. So goodbye, everyone.
Thank you. Have a good weekend.
Okay, you too.